Good morning all. So after this auspicious beginning, let us start with the sessions. Without further delay, our first session is MAFLD Cirrhosis. I'm pleased to invite our esteemed session expert, Dr. Patrick Kamal. So kindly join the stage. Since Professor Sareen couldn't make it today, may I request Professor Akash Shukla to join the stage too, as the session experts. I also would like to welcome the chairpersons for this session, Dr. Lawrence Peter, Dr. K.T. Shenoy, Dr. K.S. Somashekar Rao.
Good morning to each and every one of you for the pleasant Friday morning. So we will start the first presentation, the liver-heart axis interplay in MASH cirrhosis, current understanding and targets on the therapy. We have none other than Dr. Jacob George. I have met him many times and he is an eminent speaker, coming all the way from Sydney with a very illustrious career spreading over the last 3 decades in the field of liver disease, especially fatty liver disease. We have the pleasure of having him here. Sir, the floor is for you.
Okay. Yeah. Okay. So thank you very much to Akash and members of the organising committee of APASL STC. It's really great to be back in Mumbai and India, which is my home. And I've been given this talk titled, The Liver-Heart Axis in MASH Cirrhosis, Current Understanding and Targets for Therapy. And just by way of disclosure, I'm not a cardiologist, and I'm not a transplanter, so bear with me. So what I'm going to actually talk about is, it's not changing on the, okay. So what I'm going to be talking about is really 4 aspects of the cardiometabolic axis, and it's really looking at the etiology-independent effects of cirrhosis on the heart, the effects related to metabolic dysfunction, assessment of the MAFLD patient in clinical practice, and then finally finishing off a little bit about treatment. So as we all know, MAFLD is a multi-system disease, and the principal target organ in terms of morbidity and mortality is the heart. But we do need to remember that this is a multi-system disease involving the respiratory system, extra-liver hepatic cancer, endocrine, bone, renal, and cerebral effects, including Alzheimer's disease and cerebrovascular disease. Now, when I actually think about this topic, I really look at this paper that was published in 2022, looking at the development of cardiovascular mortality. And you could just interchange this figure and just put liver-related morbidity. And I don't know why it's not moving. Okay. So as you can see on the left-hand side at the bottom, there's rising adiposity, which actually starts the whole cascade, leading to fat mass disease, such as osteoarthritis and sleep apnea. And then you have sick fat disease or metabolic dysfunction that you get from the elevated adiposity. Subsequent to that, you get direct and indirect effects on the cardiovascular system, and just as well, it could also be on the liver. Then you develop multi-morbidity and multi-polypharmacy, and this is really a hallmark of the disease progress of people that we see today, and which is the cause of death. And eventually, we get increased lifespan, but we don't get increased health span, quality of life. So the last 10 to 15 years of life, whether it's liver or cardiac disease, we have a poor prognosis, significant disability, and a low quality of life. So looking at the effects of the heart in cirrhosis, you can think about it in two ways. The cirrhosis effects on the heart independent of etiology, and that's what we call cirrhotic cardiomyopathy. And essentially, it's very important to understand the definition. CCM is cardiac dysfunction, which can be characterized by diastolic dysfunction, systolic dysfunction, or impaired systolic response to stress, and also abnormalities in the conduction system. And it occurs in the absence of any underlying primary cardiac disease. And in various series, it's between 30 and 70% of patients with cirrhosis will have CCM. Usually it's asymptomatic, but typically it's manifest under conditions of stress such as sepsis, surgery, or critical illness. And the presentation is like any cardiac failure: fluid retention, dyspnea, reduced exercise capacity. And as we know, this is a yin and yang, and CCM can progress to HRS and relative adrenal insufficiency, and the portal hypertension can increase cardiac remodeling and worsen CCM. And this, as I mentioned, is independent of disease etiology. When you look at the hearts of patients with pure cirrhotic cardiomyopathy, there's increased cardiac weight, dilated chambers, ventricular and septal hypertrophy, cardiomyocyte edema, fibrosis, and interstitial and myocardial fibrosis. And when you think about the pathophysiology of CCM, you can think of circulatory contributors and non-circulatory contributors to the myopathy. So obviously in the liver, we have increased intrahepatic portal pressure and portal resistance with release of vasodilators. We get splanchnic vasodilation, which increases bacterial translocation. In the systemic circulation, you get increased cardiac output, increased heart rate, and activation of the renin-angiotensin system, and reductions in MAP. And there's a whole lot of neurohumoral activations, including the sympathetic axis and the adrenal and the aldosterone renin axis, as well as angiotensin and aldosterone. So all of these circulatory contributors contribute to CCM, and then there are other contributors. So we know that in any patient with cirrhosis, it impairs the detoxification. It looks like both of these are going in different ways. So these are showing the circulatory contributors to the disease. And then the other contributors include altered lipid metabolism and detoxification of direct cardiac acting drugs and liver acting drugs, including ethanol on hormones. And particularly important is the increases in bile acids and bilirubin. And the increase in the circulation can affect cardiac contractility and also cause rhythm disturbances. And a particularly important one is bile acids, because it can actually act on the sinoatrial node, giving you abnormalities in contraction, cardiac arrhythmias, and a decreased chronotropic effect. And as I mentioned before, you get microbiota changes and inflammation. Now, you can actually diagnose cirrhotic cardiomyopathy based on echocardiographic parameters. As I mentioned, I'm not a cardiologist, but you've got changes in systolic function, including a reduction in LVEF and reductions in global longitudinal strain. And equally, you can get diastolic parameter disturbances, including differences in the E to A prime ratio, the septal E prime velocity, tricuspid regurgitation, etc. And this is just a study of one of many studies, and this is a group of patients with steatohepatitis, showing that even before they get cirrhosis, they get cardiac remodeling and subclinical cardiac dysfunction, including diastolic dysfunction. So as you can see, the E to A prime ratio is increased, and the LV end diastolic pressure is increased. And as also, you will notice that as you have increased hepatic fibrosis, you end up having decreased contractility and decreased glucose uptake by the heart. So that's the cirrhotic cardiomyopathy, which is etiology independent and can be relatively frequent and subtle. However, we have to think of the heart in MAFLD in the context of metabolic dysfunction. And rather than talking about the cardiac effects of MASH, it's really more about metabolic dysfunction that affects the whole body. Remember that we can see fatty streaks as young as 18-month-old children. And so the way I like to think about MASH, MAFLD, and all of these diseases is to think about them as systemic metabolic inflammation or meta-inflammation. And as you can see on the top in yellow, as body weight increases, the homeostatic signals of the immune system begin to decrease, including surveillance for cancer in the liver or elsewhere, and then you get increases in pro-inflammatory signals. So the end result of that is in the brain, you get hypothalamic inflammation, you have adipocyte inflammation, in the liver we have MASH, in the muscle we have lipid infiltration giving you worsening insulin resistance and macrophage infiltration, atherogenic dyslipidemia, and then in the pancreas, we have lipotoxicity that eventually leads to type 2 diabetes. So it's not about MASH, it's really about systemic meta-inflammation. And this is really showing you how important that is. And this is a study that was actually done from Perth and published in JACC looking at hepatic steatosis and high-risk coronary plaque. We now know that the calcified plaque is fairly stable. It's the high-risk plaque that we got to be worried about. And at the bottom left-hand side, what you can see is that it's characterized by spotty calcification, the napkin ring sign on the far right side, the positive remodeling index, and the low attenuation plaque that you can see. This is the high-risk plaque that occurs in cardiovascular disease. And when you look at this meta-analysis, when you have hepatic steatosis, there's an increased risk of high-risk plaque that predisposes the individual to cardiovascular disease. Now, this should not be confused with this sort of data, and there's a lot of data about this ever since Lazo published in the BMJ that hepatic steatosis is not associated with incident clinical cardiovascular disease. So this is just one of the studies. This is from the multi-ethnic study in 10,000 patients. And if you look at it, the red box, when you adjust for all the risk factors, age, sex, diabetes, hypertension, smoking, dyslipidemia, steatosis does not link to cardiovascular disease or cause mortality or cancer. So are the two findings incongruous? Well, they're not. What we know is that when you actually put anything into a multivariate model, the proximate risk factors, hepatic steatosis is a very, very early manifestation. Once you get hepatic insulin resistance, then you get systemic insulin resistance. You also end up getting all the downstream effects, atherogenic dyslipidemia, type 2 diabetes. And so, of course, when you correct for all of those, it's natural and to be expected that the hepatic steatosis itself won't contribute. However, the issue becomes slightly different when you look at patients who in their MAFLD liver gets inflammation and fibrosis, which signifies worsening metabolic dysfunction. And this is a nice study from the UK Biobank, 33,000 individuals, and they looked at iron-corrected T1, which is a marker of inflammation, ballooning, and fibrosis. And when you look at cardiovascular events, you can see that those with increased corrected T1 had an increased risk of cardiovascular disease. So as inflammation increases, you get increased cardiovascular disease. Now, I just put this up. This is a slide from 2008, a long time ago now, 17 years ago. And this is looking at the pathogenesis of cardiovascular disease in type 2 diabetes. And what I would suggest to you is you could have this exact same slide when you're talking about MAFLD. We get atherogenic dyslipidemia, age and gender and race affected, inflammation, hypertension, smoking, and insulin resistance. Everything that happens in diabetes happens also in cardiovascular, in MAFLD. And this is really just to highlight that. When you look at the bottom and look at MASH and MAFLD prevalence in populations with known comorbidities, you can see that 90% of patients who are obese will have MAFLD, 50% will have type 2 diabetes, and 22% will have hypertension. All the risk factors for cardiovascular disease. And because of this, not unexpectedly, cardiovascular disease is the most common cause of death, whether it's in non-cirrhotic or cirrhotic individuals with MAFLD. So how do I, as a clinical hepatologist, manage my patients? The first thing I do is we're living in a world of metabolic dysfunction. That is the commonest cause of death in our patients. So I think even as hepatologists, increasing burden of our cases is going to be related to MAFLD. And so I use cardiovascular risk calculators. They're very, very easy to use. And there are multiple ones, and there's probably an Indian cardiovascular risk calculator. And they talk about 10-year risk, for example, based on the Framingham study or the ASCVD data. And low risk is less than 10% risk over 10 years. Very high risk is greater than 30%. Moderate is 10 to 20%. And this then gives you an idea about the risk for your patients. Now, the problem with all these cardiovascular risk factors is those risk factors were given, and they put people at low or intermediate or high risk based on a 10-year horizon. But the development of cardiovascular disease, the development of MAFLD and cirrhosis is a 30-year horizon. So just having a low risk is actually meaningless for me as an individual patient. We need to be treating that patient even if they have a low risk, because you don't want to wait till they've got atherosclerotic plaque, high-risk plaque, and then begin to treat their disease. So how do I actually manage as a hepatologist managing these patients? And this is what I do with every single MAFLD patient. The first two, which is diet and physical activity, I don't want to actually go into. Their talks in itself. But I do emphasize, what is a healthy body weight. And for Indians, as you know, the BMI should be less than 23. But for an Indian to have the same cardiovascular risk as a Caucasian person at the age of 25, you need to have a BMI for an Indian of 20. And so the lower the weight, the better. And that's what we've got to be talking to our patients. We need to have blood pressure at 120 on 80, but otherwise really got to treat patients aggressively for blood pressure at least less than 140 on 90. And your LDL cholesterol really depends. So for a person with low risk, you can think of an LDL of less than 3, and with a very high risk, you go down to an LDL cholesterol of less than 1.4. In my own liver practice, I'm very, very happy to treat patients with statins and manage their lipids and their triglycerides with a goal of less than 1.7. And particularly those with early disease, you want to get their diabetes under control, ideally with an HbA1c of 7. With the range of drugs we've got now, it is no more good to just say, well, they've got a good HbA1c of 7.2 or 7.5. It's really got to be less than 7 because the time horizon is 30 years for these individuals. What about the treatment for cirrhotic cardiomyopathy? In other words, individuals that have cardiomyopathy in the absence of any coronary artery disease. Now, this is a rare situation in the MAFLD patient, but the armamentarium of drugs that we have for cirrhotic cardiomyopathy has increased. So with systolic dysfunction, we can talk about ACE and ARBs, beta blockers such as carvedilol, diuretics, the MRAs such as aldosterone and finerenone, neprilysin inhibitors, and SGLT2 inhibitors. For diastolic dysfunction, we can talk about beta blockers and ivabradine. And again, for EP abnormalities and rhythm abnormalities, we can think of beta blockers. The new kid on the block in terms of cardiovascular prevention, of course, is the incretins, and perhaps we'll get data on all the incretin analogs and the glucagon receptor agonists. And the whole field was turned upside down by the SELECT study. 45-year-old individuals or more, 17,000 individuals. And what they looked at, 3-point MACE, myocardial infarction, a stroke, or symptomatic peripheral artery disease, no diabetes, and a BMI greater than 27, and they were treated with 2.5 milligrams of semaglutide. And what they were able to show over 3 years was the cardiovascular event rate. The 3-point MACE was reduced by 20% in those individuals. So, and the interesting thing is that the cardiovascular risk reduction in the semaglutide group occurred irrespective of whether you lost weight or not. So now for primary prevention of cardiovascular disease, we're really talking antihypertensives, lipids, diabetes control, smoking cessation, and we're thinking now of semaglutide as a primary mechanism to treat cardiovascular disease. And we can see that in that SELECT trial, if you had a FIB4 greater than 1.3, again, you reduced your 3-point MACE by about 20%. The actual problem in the individuals and separating CCM from MAFLD can be difficult because most of our MAFLD patients, as I said, will have cardiovascular risk factors. So most of them, to differentiate CCM and coronary artery disease, will need coronary angiography. And we need to think about right ventricular function also points to ischemic cardiomyopathy. I haven't had time to talk about portopulmonary hypertension and hepatopulmonary syndrome, but obviously that is one thing that we need to do. So just to summarize, cirrhosis is associated with a range of abnormalities, including systolic, diastolic, and rhythm disturbances. CCM risk increases with the severity of cirrhosis. MAFLD and MASH is metabolic dysfunction leading to a significant burden of ASCVD and risk factors. Hepatologists now need to consider risk factor management in clinical practice in conjunction with their cardiologists. And new metabolism-targeted drugs such as semaglutide can actually treat both the liver and the heart. But I think with a 30-year horizon, we need to actually think about early intervention and early management. So thank you very much. This is actually a slide from a patient of mine. He actually had myeloid leukemia, got cured, then he got MASH and all the metabolic complications, and he's in our unit. We've been treating him, and he's just so grateful that we've offered him holistic care. So thank you very much. This one.
Are we taking questions
This
now,
one,
later
this
then?
one. So this one only moves out, and this moves out.
That was an excellent talk. I'll invite Dr. Puneet Puri to have the next talk on targeting mechanisms of cell death, apoptosis, necroptosis, pyroptosis, and keroptosis. MAFLD. Dr. Puneet Puri, please.
Okay. There you go. And this is the training slides. Is there a pointer for it? And there's a pointer. Can you start your
Morning, everyone. First of all, thank you to Akash and the organizing team to invite for this very interesting team conference. And kaisa hai Josh after George's great talk. So I hope you can all start. I'm tasked to speak on targeting mechanisms of cell death in MAFLD and MASH. And no disclosures. These are my own opinion, not representing the government on their part. So the key concepts that I would like to talk about today will be an overview of programmed cell death, and that would be covering areas of apoptotic and non-apoptotic cell deaths that include necroapoptosis, ferroapoptosis, and pyroapoptosis, as well as the human studies that may relate to targeting programmed cell death in treatment. So some key concepts about apoptosis. It's the cell and nucleus shrinkage with nuclear chromatin condensation, which is a characteristic morphologic feature with karyorrhexis, and the formation of apoptotic bodies and cell fragmentation. In contrast, necroapoptosis is an organelle swelling with cell membrane rupture, cell lysis, loss of cell membrane integrity, as well as the nuclear chromatin deficiency. While pyroptosis is characterized through an injury trigger, central of which is inflammasome, there is also presence of, I have to do both, I think. Okay, and like endoscopy. So, DNA fragmentation, nuclear condensation, as well as nuclear pores. On the other hand, ferroptosis, which is primarily triggered with iron overload and lipid peroxidation, represents cellular swelling, mitochondrial changes, including disappearance of cristae, as well as increased density of the mitochondrial membrane. So primarily, like a changes happening at the level of mitochondria, as well as the rupture of the outer mitochondrial membrane. There are some key markers that are used. On the left side, you will see apoptosis. Caspases are some of the key ones, as well as increase in the bags and decrease in the BCL2s. On the other hand, the necroptosis, there is an increase in the receptor interacting protein kinase 1 and 3, which is RIPK, as well as MLKL, which is the mixed lineage kinase domain like pseudokinase. So these are some of the biochemical markers that represent necroapoptotic phenomena. And for pyroptosis, the biochemical features represent that increase in the caspases, which is 1 and 7 in this particular situation, as well as the GSDM, which is the gasdermin. And then there are interleukin 18 and interleukin 1 beta. In ferroptosis, there is increase in the ferrous iron, as well as the ROS and lipid peroxidation, which is one of the key features in ferroptosis. And there is also increase in the acyl coenzymase synthetase long chain family member 4 and GPX, which is the glutathione peroxidase and glutathione itself. So these are some of the key differential biomarkers in these 4 different processes that define cell death. Now, we'll start with the mechanism for apoptosis in MAFLD, as can be seen here. Triggered by inflammatory markers like TNF-alpha, extrinsic pathway mediating through the death receptor and caspase pathways 3, 6, 7, as well as the intrinsic pathway, which is again free fatty acid or lipotoxicity, high fatty diet, and the oleic and the palmitic acid, cause ER stress, direct changes onto mitochondria, mediating into the apoptosome, and then again through the final pathway of 3, 6, 7, via caspase 9, they are resulting into the apoptosis process. Shown here are some of the targets in blue that can inhibit, and some of these are just like empagliflozin that can inhibit the ER stress, one of the triggers, Here you can see the junk and the chop that can be like, again, apoptotic markers of cell death and cell injury. Now, prior to this, the ER stress resembles or is unfolded protein response is the mechanism. Three pathways, ATF, IRE, and PERT, and downstream of this, XBP, and then they all lead to cell apoptotic death. And we were the first one to show in humans that activation and dysregulation of unfolded protein response in non-alcoholic fatty liver disease, that was the term in 2008. And as shown here in the panel A, which is again demonstrating the PERT pathway, this is the ATF pathway, this is the IRE1 pathway, and this is again the demonstration of dysregulation. There's absence of splicing that can be seen here in the spliced XBP compared to the unspliced XBP, suggesting ER stress was mediated through the pathway of unfolded protein response. And the downstream changes were notable with phosphorylation of P38 and phosphojunk, which was specifically high in NASH compared to NAFL. And this is shown here in the protein markers. Again, suggesting that there was a pathway from unfolded protein response, ER stress leading to apoptosis. And demonstrated here is the tunnel staining, which is what is reflected on the right side, which is the NASH that has the highest activity for apoptosis compared to that with NAFL, and which was both significantly elevated compared to the normal controls. So we concluded that there is a variable degree of unfolded protein response activation in both NAFL and NASH. Although both NAFL and NASH are associated with the PERT pathway, that's phosphorylation, there is a failure to activate downstream recovery pathways, which are the ATF, CHOP, GAT34. NASH is also specifically associated with failure to generate the splicing of XBP1 and activation of junk. So these are some of the targets in therapy for MAFLD. I'm not going to belabor and bore you with that. There are too many of these, but I'll focus on a couple of those. And this was the recent study that just came out in hepatology that looked at the effect of empagliflozin on the effect on liver fat. And patients were randomized to empagliflozin 10 milligram daily and compared to the placebo arm. And there was a significantly greater decrease in the hepatic fat as noted by the PDFF measures. Now, there's another story because caspases are central to the apoptotic pathway. There was this randomized control trial for M.I.C.E, which was studied specifically in patients with NASH and F1 to F3 fibrosis. And the conclusion was that this study did not improve liver histology, as well as the fibrosis was not improved despite the target engagement. A further study that was looking at the cirrhosis and portal hypertension showed that there was, again, despite the reduction in the biomarkers with the HVPG improvement, it was not significant, and M.I.C.E was not associated with improvement on HVPG or clinical outcomes in patients with NASH-related cirrhosis and severe portal hypertension. And compensated patients with higher baseline HVPG had evidence for small treatment effect, and again, M.I.C.E treatment appeared to be safe and well tolerated. So targeting the pan-caspases did not show to be of clinical gain. Now switching gears to necroapoptosis, and this is again lipopolysaccharide and TLR-mediated pathways, trail, FAS, ligand, again leading into caspase inhibition, and through a variety of ROS activation. The key center pathways are again the receptor interacting protein kinase, RIPK, and the MLKL, which is what finally breaks down the membrane in necroapoptosis. And again, elafibranor is one of the drugs that can be used and has been tried. We recently got approved for PBC, but it did not show the benefit in patients with NASH. And so it was discontinued. And there was another study in, again, non-humans that showed that metformin, which is a commonly used medication for type 2 diabetes, activates the tetrapolin TTP via the AMPK SERT pathway, and both in hepatocytes as well as Kupffer cells, and that inhibits the production of TNF alpha, thereby reducing the hepatocyte necroapoptosis. What about pyroptosis? So pyroptosis again goes through two pathways, and those include the canonical signaling pathways and the non-canonical signaling pathways. And in the canonical pathway, high fatty diet can, through either PAMs or DAMs, can trigger the downstream mechanism of NF-kappa B, NERV2, hemoxygenase, and ultimately activation of the inflammasome through NLRP3. Similarly, you can see that this pathway directly bypasses NFLRP3 through the non-canonical signals and could be caspase-mediated 4-5-11. The end result being pyroptotic cell death, again, predominantly a very heavy inflammatory injury. So next, there is the mechanisms of pyroptosis, which is primarily led by excess iron overload and lipid peroxidation. As shown here, high fatty diet again can result into the activation of the TRF as well as the member systems here with the cysteine and glutathione, resulting into the glutathione peroxidase activation, as well as further leading to lipid peroxidation, and which can cause injury both to the mitochondria as well as the break through the ER-strep pathway that we talked about. So what is so special about this? So we, some years ago, almost 15 years back, demonstrated that there was activation of the lipid peroxidation. Shown out here are the N6, the PUFAs in the NAFL in the above panel and NASH in the bottom panel, red indicating significant elevated concentration in plasma lipidomics. And these were significantly higher both in NAFL and NASH for the pro-inflammatory PUFA pathways, which are critical to leading to lipid peroxidation. There was also increase in the de novo lipogenesis as shown by all the reds here, the monosaturated fatty acids, and both in NAFL and NASH, B being NAFL, C being NASH. This was further confirmed that there was paroxysmal dysfunction, as was noted by the presence of the DMs, as well as the conversion in the NASH pathways, that both in phosphatidylcholine and phosphatidylethanolamine, that these protective acids were DHA to DPA ratio was higher, suggesting that paroxysmal dysfunction was there. Oh, sorry, I forgot to. And there was also correlation to the icosanoid metabolites, both like 5-HETE, 8 and 11 and 15-HETE, indicating that icosanoid activation was associated in this PER. So when we looked at the circulating lipidemic model for MAFLD pathophysiology, it shows that both lipoxygenase oxidation, activation, oxidation of lipids, and de novo lipogenesis as well as paroxysmal dysfunction was noted. And this was more pronounced in those that had NASH compared to NAFL. So pyroptosis, these are some of the potential targets like resveratrol, quercetin, and curcumin. And there are a couple of recent studies that look at the role of these in fatty liver disease. So quercetin intervention reduced hepatic fat in patients with non-alcoholic fatty liver disease in this randomized controlled trial. And they studied 41 patients that were randomly assigned to either receive quercetin or placebo capsule for 12 weeks, and then they were switched interventions for another 12 weeks. The primary outcome was intrahepatic lipid component, and the secondary outcomes were liver function measurements and the safety. So they concluded in the study that 12 weeks of treatment of quercetin could reduce intrahepatic lipid contents in patients with MAFLD, possibly explained by a slightly larger body weight loss in this quercetin group. What happens to curcumin? So this was just published, phospholipid curcumin Miriva, that showed that it improved liver histology and kidney disease in NASH patients, which is again a randomized double-blind controlled trial. And in this study, patients were randomized either to receive placebo or Meriva, 26 each, 72 weeks. There was a significant reduction in NASH resolution, fibrosis improvement, at least one stage, and there's at least fibrosis improvement for more than 2 stages as well. That was seen in the Meriva group compared to, and chronic kidney disease progression was also improved, or symptoms improved. So finally, the crosstalk between the 3 main pathways, pyroptosis, apoptosis, nephroptosis, and how these terms could be led to panapoptosis and interact with ferroptosis. So there is a complex interaction. It's not one particular mechanism, but multiple mechanisms coexisting together. So to summarize, cell death on the left side column, again, effect on MAFLD, it could be protective or harmful. Key players being caspases, BCL, and the caspase inhibitor, like we talked about, Americasan did not show significant improvement. Necroapoptosis, the key players are RIP and the MLKL, predominantly inflammation and fibrosis, and then metformin and elafibranor potential candidates. Pyroptosis, NLRP, again, highly inflammatory, and then there are liraglutide lean trial that showed some benefit, NLRP inhibitors and IL-1 blockers. Finally, in ferroptosis, the primary stress is oxidative stress, and there are inhibitors, especially dietary role currently, quercetin and curcumin and iron chelators. Thank you for your attention.
Thank you, sir. That was a nice talk. We'll quickly go to the next talk. It's none other than Professor Ajay Juseja. Talk is on neurocognitive decline in MAFLD, hepatologist perspective on implications for management.
No, I'll take it off. Don't worry. Thank you. Go to the first slide.
So good morning, everyone. At the outset, my sincere thanks to Akash and his team for this kind invitation and also giving me this difficult topic. I was not keeping well. And when I asked him yesterday, why did he said, I have chosen these topics because he wanted to listen to all these talks. And there he is sitting as a session expert, listening to all this. But I must tell him and thank him that this actually gave me an opportunity to go through this area, which we have been working, we've been trying to work on this area for the last many, many years, but then was not really happening. So what I'll do is, and this also gave me an opportunity, I must tell you, that to give me an opportunity to make some new slides, I must tell you. Because otherwise, the same kind of slides were, almost all the talks were kind of going on. But this is the only one slide I have, which is old from my older presentation. And this I've kept it only for my younger colleagues because if Jacob George was using MAFLD, Puneet was using MAFLD, I'll be using MAFLD and NAFLD interchangeably. So please don't get confused. This is all the same. And this is our own data from Indian Consortium. I always show this slide. We are close to now 10,000 patients. This is a 7,000 patient data. And where we said that there's 98% similarity between the two. So don't worry about this. And as I said, the data which I'd be showing would be predominantly showing you NAFLD, but NAFLD, MAFLD, they're all the same. Let me give you first start with the concept of what we call the PROs or the patient-related outcomes and their measures. They are called PROMs. So PROs, which means that most of the patients with fatty liver disease or steatotic liver disease, when they come to you early on, they do not have any symptoms related to liver disease. They will come to you they call them as non-specific or extrahepatic symptoms. And majority of them, are fatigue, pruritus, depression. But then look at here. anxiety, depression, started coming in. They started affecting their health-related quality of life. And then an area started being, looked into was that these patients could have what they call cognitive dysfunction, which means this could be affecting their emotional health and overall affecting the patient-related outcome. When we say PROs mean these are the outcomes or the symptoms which the patient reports to the physicians. So this PROs getting affected and cognitive dysfunction started becoming as one of the areas where people, started looking into this. So there have been many studies on this since 2012, I must say. But the first study probably came in 2016. I'll not be able to show you all the data on this. This is one table which I picked up just to, summarize what is available in the literature is, first is that most of these studies which have looked into cognitive dysfunction in patients with MAFLD are either ultrasound based or other non-invasive tests. There are very few studies which are biopsy based. So some people even had a thought that is it the severity of the liver disease? Do they already progress on to advanced chronic liver disease? Or they already have cirrhosis, which is affecting their cognitive dysfunction, or it is early part of the disease. So I think we'll discuss on that. The second is, if you look at the cognitive domains which they have looked into, there are 2-3 major domains. One is the attention and the memory span, and again, executive function, and maybe the visuospatial function. So these are some of the domains, cognitive domains, which most of the studies have looked into. And the tests, neuropsychological tests which they have used are again predominantly these are the digital symbol substitution tests, this trail making tests, again digital symbol substitution tests. Most of the tests some of you would be knowing which we use for M.I.C.E. or minimal hepatic encephalopathy, almost similar to those kind of things. So with this, as I said, I'll be showing you data on maybe 2-3 cross-sectional studies and maybe one case control study to make a point that yes, the cognitive dysfunction is a reality in patients with MAFLD without cirrhosis early on in the disease. So this is one study, 2016 NHANES survey, less than 60 years of age, and they evaluated cognitive evaluation on these tests which I just told you. The SRRT, the symbol, digital substitution test, STST, and all this. And what they found was that all domains were affected. But, when you look at the cognitive dysfunction in any individual, other than MAFLD, there are various other important risk factors. And most important we know is age is a very important thing. Your obesity, hypertension, all the metabolic risk factors, they do affect your cognitive dysfunction. So then what they did was they controlled for all these metabolic risk factors. And what they found was that the SDLT, this serial digital learning test, these results were unchanged even when they controlled for all these metabolic risk factors, which means that the MAFLD was kind of independently affecting the cognitive dysfunction. And then they also looked at the relationship with liver enzymes, and as the liver enzymes, they were higher, they were correlating with the lower performance. And they kind of hypothesized that this could be related to either insulin resistance or maybe systemic inflammation, which we know is a milieu in most of the patients with MAFLD. And this obviously, I think the clinical impact for this could be that we know the magnitude of MAFLD, and this could actually have a public health impact. Then came another study from Zubair Yunusi's group. Now, as I said, metabolic risk factors or metabolic dysfunction are very important reasons for cognitive dysfunction. So this particular study from Zubair Yunusi's group, they kind of, they took patients with or without diabetes, and then they said that whether this was the diabetes which was affecting the cognitive dysfunction or was it the MAFLD. And what they found was that alone MAFLD was not really, affecting much of cognitive. Alone diabetes was affecting cognitive dysfunction. But when it was diabetes and MAFLD together, the cognitive dysfunction was more effective. So they suggested that yes, the MAFLD could have an additive effect in contributing to cognitive dysfunction in these patients. So which means that in addition to managing diabetes, not only for liver or cardiovascular risk, you also have to manage diabetes well in patients with MAFLD for their cognitive performance as well. Then this is a Framingham heart study. Again, they also looked at the similar kind of, they made the diagnosis of MAFLD. Is the time up? I still have 8 minutes to go. Okay, so this particular study again looked at the MAFLD diagnosis based on CT and the severity or MAFLD fibrosis score. And what they found again was that all these cognitive testing was affected in patients with MAFLD. But as the severity of liver disease increased, your cognitive dysfunction also kind of increased. And finally, I'll be showing you this one case control study. And why this study is important is, one, this is a case control study. Secondly, they took patients with biopsy-proven MAFLD, which I said in the earlier studies, they were non-invasive, ultrasound, NITs and all that. And some people were doubting that they already had progressed on to maybe or advanced chronic liver disease. Some of them could even have cirrhosis. And this could all be M.I.C.E, which we were studying and not really. So this particular study, non-cirrhotic patients with MAFLD, again, they used all these psychometric tests. And what they found was that all these tests, especially the M.I.C.E test, what we use, the face and the stoop and all these were kind of affected. And then they again divided these patients into histological, NAFL and NASH. And what they found was that there was no difference between the two groups. And then they also had historic controls as cirrhotics. And what they found was that the cognitive dysfunction was lesser in these patients with MAFLD, those who were non-cirrhotic, versus historic cirrhotic, where it was close to 65% and around 30% in MAFLD. Now coming to, what is the pathophysiology? Why these patients with MAFLD would have neurocognitive dysfunction? Again, I think the time will not permit me to get into all the details. It is multifactorial. But 2-3 things which are well understood are that MAFLD is a stage of systemic and neuroinflammation. We know MAFLD is an inflammation. This could be, affecting overall the cognitive dysfunction. We just heard about the cardiac and the MAFLD relationship. These patients do have, increased carotid intima media thickness and in early atherosclerosis, which could be affecting their cerebral blood flow. Obstructive sleep apnea is well associated with MAFLD. But 3 more things which are coming up. One is the neurodegeneration. Second is the urea cycle dysfunction and the role of hyperammonemia in non-cirrhotic MAFLD. And finally, the role of gut microbiota. So I'll just show you maybe one study each on this. So again, this is the group, the Karen and the Raj Mukherjee. They probably have done the maximum work in this area, and we have been trying to collaborate on some of the areas with them. And this is, again, there are not many preclinical studies or animal studies on the neurodegeneration in MAFLD. And this one particular study is a systematic review of, I think, many studies of these. They identified these 30 studies. And what they found was that there was an element of neuroinflammation and neurodegeneration in these preclinical rodent models of, MAFLD. But the time which I would like to spend now is about this urea cycle dysregulation and the role of ammonia in MAFLD. We all understand that liver plays a very important role in kind of metabolizing ammonia and converting into urea through the urea cycle, and liver is the only site which does it. So now I think I can't use the pointer here somehow. But then if you look at this is, these are some of the enzymes which are involved in the urea cycle, and 2 major enzymes are, one is this called the ornithine transcarbamylase, OTC, and the second one is this carbamyl phosphate synthetase, CPS1. So somehow in MAFLD, what happens is, once you have hepatic steatosis, these lipid droplets, they cause some kind of epigenetic changes, so-called the DNA hypermethylation, and the genes of these 2 enzymes get affected. Once the genes of these 2 enzymes get affected, their expression goes down, so the ammonia is not converted into urea, and there is a state of what we call the hyperammonemia, which happens in patients with MAFLD. And this they have shown in this particular study. This study was, they had both the animal model, the rat NASH, and also patients with MAFLD, and then they divided them into steatosis and NASH. And what they found was that the gene expression of these two particular gene, the OTC and CPS1, had gone down. There was a hyperammonemia happening in these patients, and this was all happening because of the DNA hypermethylation of these particular genes. Ammonia or hyperammonemia, which happens in MAFLD, not only affects the cognitive dysfunction, but has also been shown to affect various. And one of the areas which people are now saying that this could also be responsible for the progression of disease in fatty liver disease, which means from steatosis to NASH, this could be, affecting hepatic fibrosis, cognitive dysfunction, also causing maybe sarcopenia, infection, and even malignancy. Lastly, the relationship between the gut microbiota and the neuroinflammation and so-called the gut-brain axis is coming up in a big way. There are various ways that the gut microbiota can actually affect the brain, and this could be directly through the gut metabolites or through various hormones or through the immune cells, and also maybe through the peripheral afferent nerve and the central nerve connections. So finally, maybe I still have around 2 minutes with me about the clinical implication for all this cognitive dysfunction which is happening in these patients. So we know, yes, this does affect their physical activity, their productivity, and this has a huge societal impact, because look at the magnitude of MAFLD we have all over the globe. So what we can do, can we increase the urea cycle enzyme activity, which you do in cirrhotics? So what you do in cirrhotics is you give them high protein diet. You can use glucagon. You can use non-selective beta blockers or zinc to increase the urea cycle, but we do not have any data so in patients with MAFLD. Can you use the ammonia lowering drugs in them? Yes, lactulose, rifampicin, Lola, ornithine phenylacetate. Again, for the cognitive dysfunction, we really do not have any data, but I'll show you one slide on this. And finally, can you tackle the gut microbiota? This is one study, again, from Karen and Raj Mukherjee's group, where in an animal model, they used the ammonia scavenging, and they showed that once you use that, and they use this molecule called the ornithine phenylacetate, and what this showed that once you reduce improve the urea cycle and reduce the ammonia, the liver disease improved. They did not show the improvement in the cognitive dysfunction. And finally, I think GLP-1 data was shown by Dr. Jacob George. Again, they are also coming up in a big way in improving the neurodegeneration. So let me summarize, ladies and gentlemen, what I said in the last 15 minutes is that there is a cognitive decline in patients with MAFLD. This is in the tune of around 30 to 50%. And the domains which are predominantly affected are the attention, memory, executive function, visuospatial, spatial, and they all probably increase with the severity of the disease. But there are studies to show that this cognitive dysfunction could be similar in NAFL and NASH. The pathogenesis is multifactorial, but probably is related to systemic inflammation, urea cycle dysregulation leading on to hyperammonemia, and the gut microbiota could be playing a role. So what we can do, and we can probably target the ammonia, could maybe use the some of the other drugs which are affecting the gut microbiota, but then we must understand that I think we need more data on this. This probably has a societal impact. This does have an effect on their physical activity, their productivity, and I think we need more data to work on this area. Thank you very much for your kind attention.
Thank you, Dr. Suseja. Dr. Shukla,
we can call the speakers, the other two speakers also for the Q&A.
I request Dr. Jacob George and Dr. Puri to be on the stage.
Hello again. Wasn't that a great kickstart to build ahead today? We thank you all the speakers. And we have 5 minutes for question and answers. I'll request all the audience to please grab a mic near you and please do share our questions.
Just to start the ball rolling, Dr. Jacob George. See, this weight reduction alone reduces fat in the liver. Is there any data like that weight reduction alone helps in cardiomyopathy?
So with the GLP-1 agonists, they've already published. So, specific cirrhotic cardiomyopathy type studies haven't been done. But in the SELECT trial, it improved cardiovascular outcomes. And when they've actually done it in HFpEF with, heart failure with preserved ejection fraction due to coronary artery disease, even in that, semaglutide was actually very effective. So it does have an effect in the systolic, impacts the systolic dysfunction that you see in the usual population of cardiovascular disease. Whether it has an effect in that same, the small group with CCM or cirrhotic cardiomyopathy, there's no data. There's no mechanistic reason to say why it shouldn't be the case. I suspect it will be the case. And it's also important to remember that the GLP-1 agonists, they have both direct effects through weight, but they also have effects on altering the immune system, reducing inflammation. So there are multiple effects. It's just not about weight loss. And it's important to note that in the SELECT trial, the cardiovascular risk reduction was equivalent in the semaglutide group, whether you lost weight or not.
I have a question for Professor Puneet. You talked of the 4 mechanisms of cell death in NASH. My question is there any phenotypic correlation with these mechanisms, or is there a way to identify which mechanism is working in which patient, in what proportion, and so that you can decide to target?
I think this is a great question, Akash. I don't think I have the right answer because this is a difficult study in actual humans to study because you're capturing a cross section, and with that cross section you are capturing what was the predominant mechanism. And traditionally, we study one or the other, but if people want to really focus on identifying multiple mechanisms, there will be clues like some overlaps do exist. So that gray zone would be very hard to differentiate. However, if there is a predominant of one particular pathway, then that could be something that is driving at that stage of the disease. But hard to say, because it is an evolution of the disease and a transformation from fibrosis progression to cirrhosis to liver cancer. Typically, those two, ferroptosis and paroptosis, are gaining more attention towards transformation into hepatocellular carcinoma.
My question to Duseja sir. Sir, your talk was very excellent. It just was an eye-opener for me that we think about neurocognitive decline only in cirrhotics. So sir, I just had a question. Though you told that all the studies control the other factors, one of the well-recognized fact is long-term statin use also leads to a cognitive decline. And most of these patients, for some reason or the other, have been on statins for years together. So your perspective about whether statins could be contributing to this. And second is, when we do a OPD evaluation of these patients, most of them have micronutrient deficiencies like vitamin B12, vitamin D. So contribution of these factors to the neurocognitive decline.
So I think that's a good question, but then, as I said, the data is very, very limited. They did look for many variables, like, as I said, age, gender, diabetes, hypertension, and even dyslipidemia, which you rightly said, and all this could affect their cognitive dysfunction. But I'm not sure, and I don't think so, that whether the statins per se were looked into these studies. And same is your point, well taken, that whether they looked into the various micronutrient deficiencies. Again, I think the data is not available. As I said, the data started coming in only after 2016. Most of it is animal work, some human data also coming in, but we need more data on this.
Thank you. I've actually got a quick question for Puneet. Most of our NASH patients will have a high ferritin. But you can do a ferry scan on them and they don't have increased liver iron. So do you think, is there a marker, is there no correlation between serum ferritin and ferroptosis, or do you need to have hepatic iron overload to get ferroptosis?
That's a great question. And as you probably know, there's not a straight answer to this either. However, there are enough data currently that demonstrate that high serum ferritin levels do relate to increase in fibrogenesis as well as higher stages of fibrosis. That's number one. They do not correlate with hepatic iron deposition. That's also true. And number three, it looks like ferritin, while in this particular setting, could be more inflammatory mediated pathway. So both ferroptosis and pyroptosis mechanisms could be interacting together. So that's in addition to the point that Dr. Juseja was pointing out, for statin, mechanistically, it should have a neuroprotective mechanism, and the association studies are generally limited by the clearance of the data as to how you look. There is currently a large clinical trial network, Cirrhosis network in USA, which Dr. Kamath is part of, and that is evaluating the role of statins in various outcomes, liver and non-liver related. So that will have more answers.
Good morning, sir. I'm Dr. Rajat from KMC Nanda. My question is from Ajay, sir. So I want to know, sir, like once the patient is diagnosed with the MAFLD or NAFLD, so now we should start looking for this neurocognitive decline on a regular basis or something?
Again, a difficult question. I don't think we are still there, but as I said, my first slide, if you look at a lot of these patients would come to you with so-called extrahepatic symptoms or non-specific symptoms. And predominantly what we see in a clinical practice is the fatigue is very, very common, right? But then they could have anxiety, they could have depression, they could have cognitive dysfunction. And yes, if these are there, I think on case-to-case basis, you can evaluate them. Right now, I think we are still not there that to make a general statement that all patients with MAFLD should be evaluated for cognitive dysfunction. I think probably not. But then on case-to-case basis, anybody pointing towards or giving you those symptomatology, I think yes, would need that. But the question is, once you find that, we still do not have data on the therapeutic interventions, whether these ammonia lowering agents, whether these urea cycle enzyme inducers, whether these will all work. For example, in cirrhotics, you give zinc, you give high protein diet, and it does improve their urea cycle. But then whether it really happens in MAFLD, we don't know. So I think we still need not many data.
Sir, the main concern, what it is like whether once we are suspecting the neurocognitive decline and we are ruling out the other causes of neurocognitive decline. Then after that, shall we do this? As you mentioned, the serum ammonia levels in MAFLD is raised. So is it advisable?
As I said, we are still not there to use it in a clinical practice, but yes, in case-to-case basis, you may do it. And I would still put it as that we need more research, more data on this. Yes, I think if you find patients like these who are reporting this symptomatology, there's no harm testing them for all these psychomotor tests or psychological, all these tests. And maybe if you want to look at ammonia also, I think that can be done. But as I said, this can be done only as per today on case-to-case basis and not as a journal for everybody.
Thank you so much.
Professor Juseja, I have a question for you here. So, when we talk of these patients and the neurocognitive decline, we know that the obstructive sleep apnea is also a very important factor. Do you think that the mechanisms, because in obstructive sleep apnea have not been very well documented actually, why it causes neurocognitive decline and gliosis, do you think both of them could be contributing, not just 1+1, but actually amplifying each other's?
You're absolutely right, and this could be all multifactorial. Not only the obstructive sleep apnea, as I said, the systemic inflammation which is going on, the gut microbiota, the hyperammonemia. So all this could be adding each other, and they could be So I think we need to tackle each one of these maybe together rather than one by one. Yeah, I agree with you.
Thank you. We agree that we had 3 excellent presentations, which has given us a lot of insight for future research, especially from the field of neurocognitive dysfunction, as well as from the point of cell death. I think the 4 factors which have been enumerated. And Dr. Jacob has given some insight whether we could do the cardiovascular dysfunction in both in MAFLD, MASH, as well as in cirrhosis, and what parameters we can use as some of these outcome measures. Thank you very much for this wonderful session, and we close.
That was a superb session. Thanks to our speakers, chairpersons, and experts. Now let us move on to the next session of the day,